face-to-face meeting. But it's been really a wonderful experience to get to interact with some of the leaders in the physical therapy profession in practice and education and research. So today, I'm very pleased to have as our speaker, Dr. Shirley Sahrmann. And so I'll read a brief introduction to her, and then we'll let her take off. So Dr. Shirley A. Sahrmann, PT, PhD, fellow of the APTA, is a world-renowned teacher, researcher, and clinician. She began teaching in 1961 and spent 54 years educating physical therapists. She was the first director of the movement science program at Washington University in St. Louis. And this program has been very influential for developing numerous leaders in our profession. Of note, including our speaker last year, Dr. Dave Sinecourt. Oh. Shirley became a Catherine Worthingham Fellow of the American Physical Therapy Association in 1986, and in 1998 was selected to receive the Mary McMillan Award, which is the highest honor of the association. So she's been very well recognized nationally. She is a prolific author, and her first book, Diagnosis and Treatment of Movement Impairment Syndromes, which was published in 2001, has been translated into 7 languages and is considered a core textbook for the profession. She, in addition, has contributed to numerous scientific publications, both as first author and as mentor to many other leaders in physical therapy. The breadth of journals in which she has published illustrates how well the universal appeal has been of her theories. She retired in 2012, but continues to educate PTs and students through continuing education courses and guest lectures like today to encourage them to embrace their responsibility to guide patients toward optimal health and functional independence through movement. In her quote unquote spare time, she is currently revising her landmark textbook. On a personal note, I had the honor of meeting Shirley at the APTA Movement Systems Summit, which was a gathering of experts across all specialties in practice, research, and education. And we spent a very intense weekend together to determine how we could transform the profession into becoming movement systems specialists. More recently, we were on a Zoom call together at a virtual meeting of fellows of the APTA, which led to my invitation to deliver this first ever virtual visiting professor talk. Despite time and pandemics, she remains passionate about the profession and educating newcomers into this unique role. So I'm very excited to present Dr. Shirley Sahrmann today.
Well, Anne, you leave me breathless, and that's hard for you to do. Thank you so much for that lovely introduction. I'm honored to be invited to share this information with you, and I'll just go right ahead and do screen share and take it to my video, my PowerPoint presentation here. Let me pull this up, and then I can concentrate. Okay, so Anne has asked me to talk about the movement system, and I'm going to throw in a little bit about how I think diagnosis is related to that. And this is sort of the why, how, and what, sort of a personal journey. And I'm making this a personal presentation because I published a paper on the movement system right after the APTA adopted the movement system as our identity. And so that's a little more filled with details and why I think it's appropriate to do. I think the other thing I ought to tell you about my background is that I am so old that I actually saw polio patients. I mean, you probably don't even know what that is, but it was this disease, and it was what we called a lower motor neuron problem. And I came in at the end of the polio epidemic. And And I worked for 9 years as a clinician, and actually the work with polio people, since they were going away, took us right into taking care of the neurological patients. So actually for 9 years, my major interest was in the patient with neurological lesions. They were just beginning to save the lives of the head injured and the spinal cord injured. In fact, I always like to say, wear your seatbelt, because in those days, any male that was 6 foot tall that was rear-ended became quadriplegic because there were no seatbelts and no headrests. The other part about all this is that I didn't know what I was doing with those patients, but being as swift as I am, 9 years later, I finally decided to go to graduate school. I'm giving you this background for the context of what I'm going to talk about. And then, and I actually went to graduate school to get my PhD in neurobiology to solve the problems of spasticity. And that's why I talk about low back pain, is because I certainly didn't solve any of those problems. But my big interest and commitment was to the nervous system. And somebody would have said to you, Shirley, one day you're going to be talking about musculoskeletal problems. I would have said, I don't know what you're smoking, but it's legal now. Because I had no intention of ever being involved with musculoskeletal patients. So that's just the gist of it, that I spent a long time in the nervous system and never intended for it to meet the musculoskeletal system, but it did. And I'm going to take you on this journey of how this led me to be so committed to this human movement system, and actually so committed to physical therapy, because there's no doubt about it. Anne got it right. I am more convinced about what we can do as a profession for the health of society than I was 60 plus years ago when I started my studies in physical therapy. So, and this is what I'd like to have you think about, because these were sort of the things that popped up for me. And I'll give you a little more context, like, how would you explain physical therapy to someone? And importantly, how do you think physical therapy is perceived by other healthcare practitioners and by the public? What do they think we do, and what do they think of us? And are we really considered doctors? And then what do you consider is the major focus of physical therapy? Is our focus on treating symptoms, our tissues, our cause? Is our focus on understanding the underlying condition? And then what do you believe is the primary cause of musculoskeletal problems? Those were the things that kind of, I certainly wasn't thinking about being considered a doctor in those days, but that everybody's going to school to become doctors. And I really wonder, in fact, I don't think we're considered doctors, and it's tied up to me with this movement system idea, as I will explain. Now, I went on and looked at your mission statement, and I know this is like preaching to the choir according to your mission statement, because it says the division works to transform West Virginia and society by optimizing the human movement system. Now, I've kind of added a few little details there that weren't in your vision statement. I think we need to do that by the development of the system, by preventing movement system problems, by the diagnosis of the dysfunction, and by restoration of its performance and its health. And you're going to do that through education, clinical practice, scholarship, and service. So you've got a big road ahead of you, and I'm glad to know that the university is headed in that direction. In fact, you probably don't know this, but actually the birthplace of the movement system was West Virginia. And one of the major contributors was Sandy Burkhart, and I'll explain how this all came about as we go through this. So no, you are the place where all this began to happen. And the reason why I welcome the chance to kind of tell this story, or the content that I put in this, is because having been part of this profession for more years than I care to remember, the way the physical therapy began is still a big influence on the perception of the profession today. And there's been lots of changes. I've certainly seen many of them. You've come in sort of the end of a lot of those changes, but I don't think those changes have been clearly communicated nor have the implications of those changes and the justifications for them been clearly communicated. And I think the other thing is that's changed a lot is the understanding of the conditions treated by a physical therapist and what our role really is. And I think we need to have clarification of where we've been, where we are, and where we need to go so that it can serve as a guide to what the future actions need to be. So the changes since the beginning of physical therapy is actually part of the understanding of systemic health conditions and the role of the physician. And you, and I do mean both faculty and students, the young physical therapists need to direct the change for the future. I've got this super senior role here, and it's a good thing I can sit down and do all this. Not really. Hopefully, I want these comments to provoke some thought about what the needed change needs to be. So I'm going to outline that for you right here. This is what I'm going to try to make a case for and what I want you to think about. These are what I consider the needed changes from the current practice to ensure our future recognition. I think we have a focus on treatment methods, and I think we need to do more about understanding the underlying condition. I think we have treatment for symptoms or the consequences of a condition, usually diagnosed by a physician. And where we are now and that we need to come on so strongly about is that we have responsibility for a body system, the movement system. We should be diagnosing those movement problems and determining the treatment. Typically, the conditions are referred to us for a limited number of visits. I think we need ongoing monitoring with yearly visits, and that this goes through the lifespan. The changes continue from a limited interest in an understanding of the condition, and I'm going to make more points about this, to an emphasis on understanding the underlying condition as related to movement. Instead of a focus on the treatment of symptoms, we should be doing the treatment of the cause, because the cause is movement. Treatments, I think, are primarily selected based on popularity of the treatment system. We're always looking for the new treatment that's coming along. And these are, and what we need to have are profession-accepted diagnostic labels of the cause of the condition. And I think it can be defined in a general picture this way. The expertise of the physician is pathophysiology, the pathological function of body systems. Also pathoanatomy. I think of the orthopedic surgeons in this case, the pathology of certain structures, not just their physiological performance, but how they are pathological, pathoanatomical problems. While physical therapists, and this is what we really have to hone in on, our expertise is in pathokinesiology. This was brought up by Helen Hislop in 1975, and it's still not used commonly, and I don't understand it. And that's movement dysfunction induced by pathology of a contributing system. So if you have a cerebral vascular accident, you don't move right anymore because of the destruction to your nervous system. And then, and this is what I'm so interested in and so excited about, kinesiopathology. And what that means is how movement induces pathology, either physiologic or anatomic. So movement can cause pathology rather than just be bad because of a pathology that pre-exists. And then this thing about identity. And believe me, we don't have a good identity out there. I can't tell you how excited I was when I heard about the APTA adopting this identity. I didn't have anything to do with it, but I was at the time in Vail, Colorado, sitting at 8,000 feet. And when they called and told me about this, I went to 10,000 feet without taking a step. I thought, this is so great. And then I thought, well, maybe this will be a statement that sits in a document never to be seen again, but they actually appointed a board work group and a task force, and then as mentioned, had a movement system summit. What makes sense about this identity? Everything that a physical therapist does is to optimize movement. so that people can function better. It is the primary outcome of any intervention by physical therapy. From the day I walked into the clinic until the time where I've almost walked out. And the movement system comprises all the contributing systems to movement. Now, historically, we've sort of focused on the contributing systems. We've looked at the musculoskeletal system, muscle maybe separately from skeletal and joints, the nervous system, and cardiovascular, pulmonary, endocrine, and all, even though they're essential to the function of the other systems, probably our direct interventions have been a little less intense than are to the same extent as they are for the musculoskeletal and nervous systems. Though we know if your heart and lungs don't function, all the others aren't going to function very long either. So this is my sort of 60-year perspective. And I do think that I felt very much in the beginning like I was a cheerleader. I was treating, as I said, polio patients and patients with head injuries, stroke, spinal cord injuries, based on the physician's prescription. Actually, we only got a prescription for the musculoskeletal patients. The neurological patients, they didn't have a clue what to say, just like I didn't have a clue to know what I was doing. And I think when I am ending my career, and ending as a diagnostician of a body system treating cause, that is a huge change. I thought I had seen the change, and I had mentioned this in my article, when I was working in the clinic initially, and an observer from the labor department came around to observe what we were doing. And they made a decision that we weren't technicians because we made decisions. They saw us making decisions, so we were declared a profession. I thought that was a big jump, but I still felt very much like a cheerleader. I'm still a cheerleader, but doing it on a different level. So here we are with the movement system, its relationship to diagnosis. And I won't go into any kind of detail about movement system impairment syndromes, but those have been sort of an offshoot of this focus on the movement system. These are interrelated and interdependent, the diagnosis and movement system, as I hope I can convey. So I kind of call this Y, stage one. And this is how things sort of took place for me, the incorporation of movement into physical therapy documents. And one of the stories that stuck home with me was I was a Missouri chapter president in 1978, and the APTA decided to take chapter presidents and teach them how to be interviewed by the public, or by some kind of a person that was relating to the public. And so it was a very meaningful experience. It was really invaluable for me. And they had a little panel that they were recording. And I was sitting next to a chapter president, and they asked him, so what is physical therapy? And he hemmed and hawed and just couldn't get anything out to describe what he thought physical therapy was. And I'm making 1,000 faces, and not very kind ones, but I didn't realize what I was doing. And actually, I wish I could say that I was doing that because I was so disappointed that he couldn't spell it out. But actually, I was so thankful they hadn't asked me, because I wasn't sure what I would say. So that kind of started me on this little quest of, how would I describe physical therapy? And how do other people look at it? And every year, I'd be part of the House of Delegates, because you get to be there, a delegate when you're president, et cetera. And I'll never forget, Gary Soderberg, who was on the faculty at the University of Iowa, would come in every year and say, and so what is our body of knowledge? What is our body of knowledge? And I too wondered, well, really, what is our body of knowledge? It wasn't cheerleading. I wanted to know exactly what it was. And then I was fortunate enough to be on several national committees with some of the real important people at the time. And the question always came up in these meetings. So how would we describe physical therapy? How would we define it? And then I became a candidate for the APTA board of directors. I was about 1979, 1980. And part of my promotion was to try to get us to say we need to put movement into, we need to spell it out clearly that what physical therapy is about movement. Well, I was elected to the board of directors and then also served later on a task force for the definition of physical therapy. And bit by bit, and it was kind of funny because I'm sure Ann knows Cindy Zadai, and we would have these arguments as I was pushing the idea of movement, and Cindy would say, well, you're going to leave us out because we're cardiopulmonary people and movement doesn't matter. I think she's changed her mind substantially since then. I know she has. And then actually Cindy was on the committee with me, or the task force for the definition of physical therapy. Another major player that affected my life and actually was a good friend of Sandy Burkhart's was Steve Rose. And Steve was a very prescient, farsighted guy, and he came to be director of the physical therapy program at Washington University in 1979. And Steve came with a commitment to develop a curriculum that was going to be based on pathokinesiology. He saw the value of trying to have the profession focused on, as Hislop had said in 1975, on an identity. And he thought that pathokinesiology really is one that made sense. The other thing that Steve was committed to that was the idea of classification or diagnosis. He had gotten his PhD from Columbia University in basic science and saw the value, as did I, because I was part of the Department of Neurology half-time for about 20 years. Oh, I forgot to tell you, I also trained monkeys and recorded from their motor cortex trying to solve this problem of spasticity. So I'm not sure whether I regressed or progressed when I went back to treating people after all my time spent with monkeys. But be that as it may, Steve pushed the idea of classification. And you'll tell from my commitment and passion about movement, system, and diagnosis that I may not come up with the ideas, but I recognize good ones when they're put out in front of me. And I'm a little bit like a dog with a bone. I'm going to hold on to that bone even if I didn't find it in the first place. Steve also wanted to have the program do research. There was none when I was a graduate of this program. There were 3 faculty, and as they say, they were 1 chapter in the book ahead of the students. It was a very different kind of faculty in those days. And of course, no research whatsoever. And Steve's big commitment was he wanted the faculty to change from being school teachers to becoming academics. And he set out with full force and energy and much prescience to have it become that way. The other major player was Eugene Michaels, who had been at when the University of Pennsylvania had a physical therapy program. And then that program was closed, and Mike, as he was called, went to the APTA office, and he too understood the importance of putting movement into a description of physical therapy. And so he helped by being on the board and with wording and concepts to help incorporate movement-related conditions into the description of physical therapy. So it seems so simple now, but it was kind of a struggle in those days to have the profession really come out strongly and say, what we really care about is movement. That's the purpose of our profession. So I thought it was nice, and I was used to treating patients that had compromised movement from my time with the neurological patient. So stage 2 is what I call the eras of physical therapy, silos of acute problems. Polio was considered an acute problem. Even though this was the 1950s, the Second World War had ended in 1945, and there was still a lot of war injuries, and they became a big source of physical therapy. And of course, those were clearly part of an acute problem. The thing about polio that I didn't appreciate so much at the time, but certainly did retrospectively, is that the pathology was pretty clear. The motor neurons died from the virus. When the neurons died, the muscles died, people got weak, and they developed contractures. And the contractures were because the muscles that were unopposed by the dead muscle would pull the parts into undesirable alignments. And so we had to brace and splint and stretch and do everything to make sure that these contractures didn't develop. And we also did a thing called muscle re-education. We had hoped that as the muscles were recovering, we could get them to function better. So, and with musculoskeletal conditions, they were considered an acute problem. And believe it or not, in those days, it was actually before you had much beside aspirin. There weren't a lot of ways to alleviate symptoms. Now, the physicians would diagnose those problems, and then we would use modalities for pain relief. And of course, there would be exercises to hopefully get the muscles stronger so that they would be better. And then we had amputations and muscle injuries also from these war injuries. As I mentioned to you, right after the polio went away, which was the vaccine was introduced in about 1955, there were still a few acute cases, but they were mostly residuals. And with the central nervous system pathologies, now the MD would, of course, diagnose cerebral vascular accident or spinal cord injury, but I had not a clue what to do. It was so challenging because we were told that you can't strengthen a muscle that's spastic because it would make the spasticity worse. We couldn't stretch the muscle because it would make the spasticity worse. So the whole treatment methods that we had developed and used with the polio patient were not to be seen again, not to be used. So what happened is we developed these treatment regimes. So there was the Bobath method, there was the PNF method, there was the Brunstrom method. All of these treatment methods developed usually by one person. And what I never understood, and they were not well disseminated at the time, but even the faculty that was supposed to teach the Bobath method or the Brunstrom method, I would say, well, how do I know what to use when? And I never got a very clear answer. With the musculoskeletal system, the focus became on joint pathology. Almost all of the people that developed treatment regimes with musculoskeletal joint problems got their beginnings with Cyriax, who was a physician in England, and they all went to train with him. And he was sort of an orthopedic medicine person who did injection and manipulation. And so then again, as with the central nervous system, the treatment methods became named for the developer. And Maitland from Australia used a method that was more gentle and little bitty grades. And then there was Kaltenborn, who was in the, I think Norway, and or Sweden, I don't remember which country he was from, and that was much stronger, more movement. But these were all passive. There was no exercise involved with these treatments when they were first evolved. So that was stage 2. So we had treatment methods that were devised, and I've kind of listed some of those here. If you were a neurotherapist, you knew about nervous system dysfunction. I didn't. I was out there before the Bobath ideas got very well disseminated. And there was a woman by the name of Margaret Rood that was also had a method, and PNF and Brunstrom. And in these methods, there was no consideration of muscle. And as I had mentioned to you before, you couldn't stretch or strengthen because the spasticity would increase. And then I didn't know whether I was trying to restore limb function to make them functional, or I should work on functional movement without the limbs getting better, or both, and for how long. It was just, which is why it took me 9 years to fully realize I really didn't know what I was doing and to do my escape to graduate school. With the manual therapist, and as I mentioned, Cyriax was the source of this, it was considered an acute joint dysfunction. And exercises really weren't at all brought up until the late 1970s. And the main emphasis was the therapist's passive motion of the joints. I always had this dilemma in my own mind about, well, it doesn't tell me how it got that way or what I'm going to do to not have it get that way again. I think what was really valuable about the manual therapy period, the time that they started, is that it was for the first time that therapists began to think about figuring out what was wrong. Before that, we were trying to do something with a condition that the physician told us was bad, but we didn't try to figure out exactly what was wrong, other than what muscles were weak and how we should strengthen them. That was a little different. They used the term diagnosis, but there was never a specific set of labels. Even when I would go to Australia or New Zealand, and I'd say, you say you're making a diagnosis, will you tell me what the names are? And I never got any kind of consistent names. It was more about what level of intervention you were using. And then I had another message from McKinsey. McKinsey had classifications. He had labels for his conditions. But the thing that was sort of the wake-up call for me was the treatment always seemed to be the same thing. It was some form of a press-up, maybe a little bit of this lateral glide if they were in a shift. But I never, and so I kept seeing therapists just focus on having the patients do some form of a press-up rather than have them really work at a different classification and a different form of treatment for the different classifications. So my sort of takeaway from all of this is that the emphasis was still on treatment, and whichever one was prevalent at the time, and not really using labels. And one of the things about McKinsey, and he actually had a paper in a publication that said you really don't need to exercise muscles. And I probably you heard the story that the way McKinsey got onto his press-ups reverse thing is that he had one of these sheep shears. He was from New Zealand, and that was his primary caseload. And one of the sheep shears had gotten on the table and was laying on it. It was raised up, and he was laying face down with his back in an arched position, and was talking about how much better he was. And so that took McKinsey on to thinking about it. Well, these are the positions they work in. And these are very hardworking physical people in New Zealand as well, not only the sheep shearers, but they're real outdoor exercising people. And so they probably don't need exercise, but they probably need to get out of flexion. So this was the position that they worked in, and you can certainly understand how they would get a problem that needed to get them out of flexion. So why? Next is movement to the movement system. And as I said before, no matter where I looked, if it was the musculoskeletal problem, they wanted people to be able to move better, whether it's by reducing the pain or getting a joint to function better, or the neurological patient to improve. That's what it was all about. And then we had this transition for me, from the lower motor to the upper motor, and trying to understand what the problem was. And I can tell you, most physicians really weren't that interested in the disordered motor control, but on how to minimize the nervous system damage. That's what their business is. We didn't get a prescription from them. They didn't tell us what to do because they knew they didn't know what to do, and it didn't really matter. They just wanted their patients to get functioning again. And so we just had a referral from them. And my whole focus was to try to retrain the nervous system and suppress spasticity. I remember I completely, even though I was like a super duper manual muscle tester, because that's what you had to do with the polio patient, not by groups, but by specific muscles. But I even put the muscles on the back burner and just think, I'm trying to retrain this brain. Orthopedic patients were considered an acute problem. We just would relieve the pain and then strengthen the muscles. Now, the MDs seemed more focused on trying to identify some pathoanatomical problem, and the prescription was actually a checkoff list. I was aghast to see that some of these are still being used, where the physician is telling you exactly what you're supposed to do. I just can't even believe that. like they would know. In fact, when I was in neurology, some of the neurosurgeons and neurologists would call me and say, Shirley, what should I check on this list? And I would just fall about laughing, like they were supposed to check it off. Oh my gosh, what a joke. But with the orthopedic patients, they didn't even consider the nervous system. It was all about stretch the muscles and strengthen them. That's what they were supposed to do. Or if you knew about joint mobilization, then you did that. Okay, so I had a little glimmer of life in my of light in my own life, because I had two friends who decided they were going to get healthy, and this is way back in the 1970s, um, early 1970s, and so they were going to start on the Royal Canadian exercises. And as a physical therapist, they asked me to take a look, and I thought, well, have a stroke and then I'll know what to do. But I certainly don't when you just are doing plain exercises. I don't know anything about that. But I didn't want them to know that I didn't know anything. So I started giving them the same thing I was giving my neurological patients to do. And these two patients, one was sort of tall and had rather good alignment, and the other one was very kyphotic, et cetera. And they both started looking better. And I thought, wow, that's really, really interesting. So I thought, and I was in graduate school. So yeah, this was late 1960s to early 1970s. I was a long time in graduate school. And so I started the exercise program. And the reason why I have a comment here, I was, after I was doing my little exercise program, I was out playing golf with a friend. And she said, Shirley, do you know you have your pants on backwards? I'm saying, like, I'm working on my PhD. I don't even know, I should know how to put my pants on. Well, lo and behold, I did have them on backwards. I had put the zipper in the front, but she showed me how the darts were wrong. But they never looked bad before I started on this exercise program, but now they weren't fitting right. I kind of knew that. Same thing, I had put my bowling ball away because I had neither time nor money to be able to bowl. And when I took it out after doing my little exercise program, my hand grip no longer fit. My fingers were farther apart because I had stretched out my finger flexors. The other thing that changed dramatically on me was my shoes. I would always wear them out, so they were shifted. They were over the edge to the right side. So I still have a little bit of a shift to the right when I walk. And then after I started this exercise program, I never wore my shoes off over the edge. They were lined up straight. So I knew that what I was doing was affected my whole performance, which was like, I wonder how this works. These were supposed to be for when you have a stroke, not for when you don't have a stroke. So that kind of stirred my thought a little bit. And then it went on to this idea of, well, I wonder if the nervous system does play a role in patients with orthopedic problems. So Steve, as I mentioned, to become director of the physical therapy educational program, for a while became the director of the PT service at the Rehab Institute. So he would draft me down to go look at orthopedic patients with him. And I thought, what do I know about orthopedic patients? I thought they were boring. I didn't like doing modalities. So I always made sure I never had any orthopedic patients to treat. So I had to start thinking about it because he said, come on, Shirley, let's go down and look at these patients together. So I started thinking again about what I had sort of learned, or the knowledge I had based on my experience with the polio patient. And then a little bit of like, I guess these people with neurological conditions have muscles too. I ought to think about that. So I would see these runners and I would actually teach them. I would give them the same exercises I gave my stroke patients. And one of them was actually an exercise in the quadruped position, because we were told by the BOBAS that we were retraining the brain and going through our developmental sequence again. I never understood that, nor did I believe it. And my neurology mentor thought that was the biggest joke he had ever heard. But anyway, I thought, I wonder if I just get these people, I was teaching them how to walk differently. I was kind of giving them specific muscle, what I called muscle re-education exercises, and changing their basic patterns. I never gave them any true strengthening exercises, but just kind of did these things that seemed to make a change in my movement pattern. And I'll just show you a little result. This fellow had been a 10K runner, but actually the true story is he was a reporter for a magazine. And he came in to do a story on our treatment of stroke patients. And then he said, what else do you do here? And I said, we look at posture. What did you do to yours? Kind of a smart alecky little thing. And he said, what do you mean? And I said, well, it isn't good. And it wasn't good. And he said, well, I did run 10Ks, but I can't because I've got back pain and foot pain. And so he said, well, show me what you do. And so I did. And you can see he has a little bulging abdomen, and he was doing trunk curls. And what he was doing when he did his trunk curl was he was allowing his abdomen to distend. So he was continuing to distend his abdomen, doing his little trunk curls. Plus, I knew those weren't the abdominal muscles that he needed the best. And so just because of time for his schedule and mine, he diligently went off doing the exercises I recommended to him. And 6 months later, he came back, and you can see how much his alignments changed from this prominent abdomen, this overdeveloped teres major, to really good alignment. He didn't have back pain anymore or heel pain, and he was 2 minutes faster in the 10K. So he was super pleased about that. And one other example I had from those days, and this was a marathonist. Actually, she was a PhD student using running to, she was in psychology to as a treatment for depression, and she was in her own depression because she couldn't run. She had hip pain for 5 months, and this was before they discovered the labrum or FAI for the hip. And so this is a little bit of the way she looked before, and you can see the change in her alignment. And this was a matter of, again, not strengthening exercises, but get her out of this little sway back alignment where she wasn't using her hip extension, her gluteal muscles, and have her use them. I had to teach her how to walk, and again, gave her a little exercise program. So I didn't understand what I was doing quite, but I thought, well, this is really interesting. These people are doing better. I'm using my sort of tricks that I got from the neurological patient, and they seem to be doing better. So we went on, and there was one other thing about the nervous system. There was one person who was also kind of looking at the nervous system in relation to musculoskeletal problems, and his name was Vladimir Janda. He was a Czechoslovakian neurologist. He had actually spent some time in Australia working with Gwen Jall and some other people there. And he actually, what was interesting about him, he had polio himself, and he had a focus on posture and muscle imbalances and was related to movement. But he talked about things in synergies, in big, broad terms, like all the flexors were tonic muscles and the extensors were phasic muscles. There was a lot of generalizations that didn't hold up if you knew the details. But he was the only one during this big time when people were focused on manipulative therapy or joint problems to talk about some aspects of motor control. I didn't really know anything about him, but Steve had mentioned to me, and later in life our path crossed. And in fact, Yonda became a good colleague of Sandy Burkhart's. Our paths crossed, Yonda's and mine, at Ohio chapter meeting, and then later we were both on a program in Scotland sponsored by a group called Kinetic Control. And then I actually had dinner with him in St. Louis, where he had was working with a chiropractor here in St. Louis. So that was the only other connection between the nervous system and orthopedics. And I sort of put this up here. These were the generalizations that Yonda had: upper cross syndrome, lower cross. He had a classification scheme. And he talked about muscle imbalance, and that was clearly where mine was going. And he said, and this is where I've ended up to be quite convinced that this is the truth, that the actual cause of pain is often secondary to muscle imbalances, and that we should find and treat the cause of the pain rather than focusing on the source. In other words, it's not the tissues specifically, it's what makes the tissues go bad. And that's kind of the way things have gone for me in trying to work out this idea of a movement system. Two other things that made me start to think about putting this all together into some kind of a movement system is Robin McKenzie actually came to St. Louis at Steve's invitation and was examining a patient. And what I remember about that so clearly, certainly I didn't know what I was doing at the time, but I was watching him, and he had this woman with back pain, forward bend and come back up. And he said, "Did that hurt?" And she said, "Yes." And I wanted to know, did it hurt on the way down or did it hurt on the way back? He didn't seem to be interested in that. He just sort of assumed it was on the way down and didn't look at all how she did it. And so later on, when I was dealing with these patients, I always wanted to know, did it hurt on the way down, or did your symptoms get better that way? Did it hurt on the way back, and how did you do it? And where he didn't look at how people moved, I was very interested in how they moved. And that was, again, my 9 years looking at neurological patients. And then one other thing that I'll never forget is that there was an article published, it was in 1996, by, I think her name is Susan Babelar. She was in New York, and she did a study and reported it on people that had shoulder pain. And what she reported in this article was that even that people that had excessive scapular elevation when they flexed their shoulder, even after the pain was gone, they still had excessive scapular elevation. Now, the paper was 12 pages, but then there was a discussion with 5 people about, do you think the nervous system is involved in these problems? And that was 8 pages long. It was such a new thought, even in 1996, which for me is like the day before yesterday. For you, it's years ago, I know, but probably before most of you were born even. But I thought this whole thing of it, isn't it amazing that we haven't put together the nervous system with the musculoskeletal system and vice versa? Everybody was living in their own little silo. So this kind of took me and Steve on to 2 different classifications again. What Steve ended up doing was adopting and modifying the McKinsey system. He liked the classification that McKinsey did, but what he did differently was he renamed the system for the treatment rather than for the condition. And so it became the TBC, or the treatment-based classification. And unfortunately, Steve died at a much too early age from multiple myeloma. And Tony DeLito, now at the University of Pittsburgh, who had been on our faculty, who had come with Steve from the University of Buffalo, completed much of the work of Steve's. And that also led to this prediction rule where they do a few tests, which really is not a diagnostic system. It should be predicting how effective the treatment is, but it's not a way to know what the treatment is. And then I'll show you a revision that they have a little bit later. So Steve was busy pushing that, and I was on faculty, and I started working with some of my colleagues to look more specifically at movement and muscle imbalances, and identifying how people moved and how it was related to symptoms and whether that movement was optimal or not. So here's where West Virginia comes into play. As I mentioned, Steve died much too early. He knew he had a very bad prognosis and left Washington University and went to the University of Miami, where he was about a year, I believe, before he died in 1989. And Sandy Burkhart organized a group of us who recognized all of Steve's contributions, and we discussed how we could carry on with many of Steve's ideas. And so Sandy organized, and I think we met a couple of times, and there was a good number of the movers and shakers of the profession that were involved in these meetings. And that's where the term came up. And I don't remember to this day who brought up the term movement system. But Scott Irwin, who was a cardiopulmonary person, also died much too young. He was a consultant for a dictionary, and he called me and he said, "Shirley, I think we ought to add this to the dictionary." And I said, "Well, I don't know anything about writing a definition, but I know who does," and that was Florence Kendall. And she was all connected with the Stedman dictionary. So, and Scott was a consultant. So I said, "Florence, what's a definition for the movement system?" And this is what we came up with at that time. It's a physiological system that functions to produce motion of the body as a whole or its component parts, the functional interactions of structures that contribute to the act of moving. The group also said there's not only movement system, but there's movement science. We were greatly influenced. I had been part of the few people involved in neuroscience. The first meeting was about 60 people, and then it grew to thousands of people. Everybody came from other departments to be part of neuroscience. And I thought the same thing should happen with movement science. So Cindy Zadai, Scott Irwin, and Colleen Keegan published this article about how movement science should be part of physical therapy education. There was even a suggestion, and I'm actually keen about this and would love to talk about it if anybody has any interest, that we should change the name of the profession. Not the profession, of the professional. I think we shouldn't be called therapist myself, and I can tell you why. So the next stage of how is reducing these silos putting them all together into a movement system, which we had first called movement system balance. And we were uniting the musculoskeletal and the nervous systems. Now, of course, it was an artificial separation, but we did little things like, instead of talking about muscle strength, change it to performance, because it includes everything from strengthening, not just stretching, but the stiffness of muscle, the re-education, and take it out of being an isolated function. Skeletal motions, put them together with accessory and physiological. Don't be just a joint person, but also look at the relationship to physiological motion. Look at the nervous system and how it recruits and what the activation patterns are, because these are intimately connected. And to me, biomechanics is the direct interaction of it determines muscles and nervous system function. And then the movement patterns of daily activities, that's what turns out to be the important part. And make the patient an active participant, not just a recipient of passive interventions. And this is a revision. I was so pleased to see this actually published in 2016, where now the TB system also involves movement control. Before it was just about relatively passive treatments. So stage 2, about how progress and refinement, I kind of tease, but it's probably characteristic of most physical therapists, except people like me, that they have OCD, obsessive compulsive disorder. And happily, my colleagues at Washington University seem to have this in full measure. So we did everything, they did everything to improve the teaching materials. They called it translating Sahrmannese into English so that it made some sense. So clarifying concepts, making sure we could find support in the literature, identifying what we didn't understand, and talking about muscle adaptations and activation patterns, clarifying terminology. I think one of our big problems in the profession is that everybody that teaches courses makes up their own terminology for the same phenomena, and that's a big problem. We were teaching continuing education courses, but I kept getting the idea that people were going away with just the message of, here's what you do for treatment, and not the message about diagnosis, which I thought was problematic. All patients were given what we called lower abdominal exercises, lower trapezius exercises, and gluteus medius. And so the concepts got put into another bunch of treatment regimes where I want it to be a diagnostic category. I don't want to really tell people this is what you should do. I want you to understand why you should do it and how you should do it. So, and then I sort of found out that actually, except for the transversus, nobody knew anything about abdominal muscle function. So that was a little disturbing. We got a small grant from the PT Foundation, as it was called at the time, to Barb Norton and myself, and start doing some research on low back pain. And then Linda Van Dillen has parlayed that into some amazing studies on low back pain, which I would love to talk about at another time, but I know this isn't the time or place. But we started combining this movement system balance into movement system impairment syndromes. We used muscle testing of key groups that we thought were important to understand about how they were affecting movement. And one of the underlying principles was, it became really clear that the spine was actually moving too much, affecting the joint movement, eliciting symptoms, not just when you move the trunk, but when you move the extremities, particularly the lower extremities. And actually a very effective exercise turned out to be this quadruped thing. And again, that takes different kinds of explanations, but that was like putting this all together. It became evidence that patterns were induced by activities. And those activities are affected by individual characteristics. They start early in life. These are not acute problems. These are chronic problems. We know that with health conditions today, they're chronic. They start early and they continue through life. So it is with musculoskeletal system. So we changed the movement system balance to impairment syndromes, and from teaching anatomy and emphasizing exercises to trying to get people to understand the importance of an exam to make a diagnosis, and pushing the idea of diagnostic categories named for the movement that induces the pain and that's impaired, and then when you correct it, decreases or eliminates the symptoms. And each one of the faculty, and I know we won't go through those with you all, but it actually took a specific region. Paula Ludwig at the University of Minnesota has done some amazing work on the shoulder, and we're kind of working with her, and she's a little bit working with us to refine our shoulder diagnostic categories. We have two people that are doing research with the hip. Linda's doing it with the low back, and then clinicians who specialize in different body regions, so that we've got a lot of checks and balances and pulling us in off the limb. So here's the Washington University graphic on the movement system. This is our body of knowledge. And I think the important thing to me is it emphasizes what we know rather than what we do. I think we suffer by the fact that people know us to do things, but they don't know that it's so complicated. They don't know that there's a lot to know. And I think the thing that's wonderful about having the movement system as your the focus is that it applies to all levels of bodily function, whether it's ions moving through membranes, how muscle physiology, or it's how you move in your environment. Our definition at Washington University was it's a system of systems, which it is, just like the immune system is, of physiological organ systems that interact to produce movement of the body and its parts. The APTA in 2019 adopted a different definition at the bottom of this that says it's the integration of body systems that generate and maintain movement at all levels of body function. They're really kind of the same thing. It's all saying it's about movement and their system of systems. Now, this is the graphic that the APTA adopted. And I know what's very big these days is the biopsychosocial model. Well, all of these systems pertain to the bio part, and you can't have psychosocial without the nervous system. And pain is a big focus these days, but you can't have pain without the nervous system. So the nervous system makes up this focus for psychosocial and for pain. The immune system, all of these other systems impact movement, and it just depends upon what you're particularly interested in. The best way to optimize all of these systems is movement, even the immune system. That's why I'm so excited about what physical therapy should do. Whether it's dementia or it's immunity, it's all about physical activity and exercise. And it has the least side effects, but some of those can keep you from exercising, and that's where our expertise comes in as also. And then Anne shared with me some of the ways that she's looking at aspects of the movement, taking subsets of these particular systems and putting them into different categories of motivation, endurance, strength, and the effects of lung cancer on movement. That to me is the nice part about this model, is that you can use it to expand it into different ways. And I just put up this little slide to say, partly because of my own health issues, physician subgroup of pathophysiology, the cardiovascular system, and the cardiologist. I had no idea. These are all the subcategories of being a cardiologist, whether you're general, echo, electro, interventional, adult, congenital. So you can take one component and divide it up into many other components, but it says, this is my focus. I'm a pathokinesiologist, or I'm a kinesiopathologist. Movement, because if you're a movement or exercise expert, you have to consider all of these participating systems, the biomechanics, the muscle physiology, skeletal physiology, biocontrol, biobehavior, as we're saying, psychosocial or biomechanics, cardiopulmonary for the bioenergetics. So it's all there in the movement system, and anyone that's really looking at how to use it well considers all of these aspects, not just the muscles, not just the joints, not just the nervous system, not just the heart, not just the lungs, but all of them. And then I won't go through this with you. This is our kinesiopathologic model, and I can see I'm running short on time, but this is how we've sort of put it all together. The idea being is that our repeated movements and sustained alignments of everyday activities is what leads us down this path. Tissues adapt like they're supposed to, but they don't always choose the right way. And we get a micro instability that leads to micro trauma, macro trauma, and a pain syndrome. So it's a physiological body system that requires an expert for optimal management, just like the experts of other body systems, neurologists, cardiologists, dentists even. Requires an expert for diagnosis and treatment of movement dysfunctions, whether the pathology in a system has caused the problems with movement, or whether movement is inducing the pathologies. We should be out there for prevention, to guide development, identify structural variations, monitor ongoing use and adaptations, and making fitness recommendations. I think movement and what the diagnoses are that we should make are movement system diagnosis, whether the movement's impaired, insufficient. And the two categories that I've mentioned, and we have musculoskeletal, neurological, and hopefully Anne will help me fill in this cardiopulmonary. I know we have a little bit of that going, but it hasn't developed as much. We've got definitely neurological, and that's going pretty well. And then I just wanted to show you what I believe is a good way to incorporate the ICF. You start with a health condition, and for the physicians, it's pathophysiological or pathoanatomical, and ours should be pathokinesiologic or kinesiopathologic, and then you run through this whole system. I don't believe we belong just here in body functions and structures, but our diagnosis should run through here, just like the physician's diagnosis runs through here. So the other thing that bothers me is that for 40 years, we've stated that PTs must make a diagnosis. Every document we have say PT's diagnosis, but there's no list. There's no specificity. That diagnosis should be a body system of expertise. I don't know whether you all realize, but we went to the clinical doctorate level because we were supposed to have direct access, and therefore we would have to figure out the conditions that didn't belong to us. We always had that responsibility. But we became doctors for that reason. That's why, not why you should be doctors. You should be doctors to diagnose your body system of expertise, and that's the movement system. It should be consistent with our examination and treatment. That we don't do surgery, we don't prescribe medications, and I hope we don't ever. What we should be doing is looking at how movement affects the tissues, because that's what injures them in the first place. We should be providing, when a patient goes to a doctor, what they want is a diagnosis. That's what we should give them, the diagnosis of our expertise. It's a way of educating other health professionals and the public so that they understand those conditions and how we can treat cause, not just symptoms or consequences. And it should support recognition for what we know. And no one's going to think we figure anything out unless we put a label on it. I think this would address our big problem of variability in practice. I think it will improve outcomes if we have movement system diagnosis and a list, and we all use them. And then all you have to do is think to yourself, where would the health of society be if physicians didn't use labels, if they didn't have diagnosis? So that's my story. I think you can tell that I'm very committed to this idea of both the movement system and movement system diagnosis, not just the ones that we've been working on, but any that are related to movement, which is, I think I did have I just wanted to point this out. This is another, and Paula Ludwig put this up the first time. I think this is so interesting. What are the average salaries? Physical therapists and nurses are about in the same category, the BSN nurse. Look at physician assistants and nurse practitioners. Why? First two, what we do. The latter two, what they know. They're going to pay you more for what you know than for what you do. We had the Movement System Summit. Again, Anne mentioned about this. We worked on a definition. We said we had some general things. There was a call for diagnosis. 90 were submitted. Nothing's happened with them. An intake exam was developed. I think they're supposed to do something with that, but I haven't heard anything about it. The summit was in 2016. It's 4 years later. There are only two of the academies are working on diagnosis, the Neuro Academy and the PEDS, which is actually working with neuro now. So seemingly we're at a standstill. And what has been distressing me is that none of the promotions for observing our 100-year anniversary are saying anything about movement system or anything about diagnosis. And it's pretty scary to me that we aren't going to change things substantially from the way we've operated for 100 years. We've gone from the fact that these are not acute conditions. We're not treating people for an acute problem. We've gone to the idea of all health conditions practically are chronic. Even how well you can deal with a virus has much to do with the health of your body and how well you've kept it going. And we've got to realize that we've got to have a very different role that's related to truly being the doctors that we're educating people to be. We got to break from keeping all of our emphasis on treatment and put it on diagnosis and understanding the conditions. And as I say, I think it would be a big help to us if we got rid of the name therapist, which is what speech people did. They're speech and language pathologists now without a change in educational level. We've changed our educational level, but we haven't changed our title. So I think that Yes, that's the end of my story, and thank you for letting me tell it.
Thank you so very much, ma'am. We appreciate all of that. I'm going to give you a little bit of a chance to catch your breath.
Fine.
And I believe, yes. So I'm going to give a shout out here to the gentleman labeled WVU DPT, because Shirley, I believe you'll recognize this guy.
Oh, my goodness gracious. Hello there. How are you? Unmute yourself. I can't believe you're muted anyway. How are you?
It's good to see you, Shirley. Yeah.
You too.
You still remember Helvetia?
Of course I do. That you heard my story. Yes,
Yeah.
you're the birthplace of the movement system.
Yeah, that was an amazing group of people.
No question about it, Sandy.
Did we know what we're doing? No. Did we
No.
get it all together? Yes, with Pam and Eugene Michaels to put that final talk together. It was an amazing moment, and it's grown tremendously over the years.
Not enough.
Not enough, but
Not enough.
change can always occur for sure.
I'm waiting. I want it to happen before I'm out of here.
Well, I listened to your end remarks. It's up to these young people now. They have to take the same challenges and stick with the profession and bring about the change.
I know I'm trying to give them the reasons in the big cell, Sandy. We'll see.
Yeah.
And they've got social media now. We didn't have that.
No,
We all had to go to Helvetia and meet together.
we don't have to go there again.
So I just wanted to make that little connection there.
Well, thank you, ma'am, for letting me say something.
Good to see you, Sandy. So for students who haven't had the pleasure of meeting Dr. Burkhart Sr., he was the founder of our program and very influential, as you heard, about development of movement system and all kinds of other things. So Shirley, Dr. Sahrmann, would you be open to questions at this
I'd love to. I hope they have questions.
Okay.
I do indeed.
So we can either do by chat or
I would like to. This is Bill Stauber.
Hi, Bill. How are you?
I'm doing fine, thanks.
How are the muscles?
That's what I wanted to tell you about. David Simon, in one of the meetings, Dr. David Simons, in one of the myopain meetings, made the comment that skeletal muscle was an orphan. It had no medical specialty to it. You had cardiologists for hearts, and the people who treated muscle, and he was interested, obviously, muscle pain, would be rheumatologists, neurologists, orthopedic doctors. He said there was no concentrated science and clinical expertise related to muscle. And you've gone one step further, of course, in bringing it together in its own entity as a movement area. But I thought that was interesting, that historically, a discipline, even in medicine, dealing just with muscle never developed.
No, the neurologist, as close as they come, is the muscle disorder clinic, where, muscular dystrophy, et cetera, those kind of degenerative diseases. But yeah, that's true. Totally true. Yeah. Well, we don't in this country actually have any, except now that physiatrists are getting to be, we don't have any orthopedic medicine people. Like you've got orthopedic neurologists and neurosurgeons, we've got orthopedic surgeons, but some of the physiatrists are becoming more orthopedic medicine people. That would be where you'd kind of expect it. But you're quite right. I just assume that physical therapists do it myself. Wouldn't you, Bill?
Absolutely. That was my feeling when we were talking about it, that this was our whole area.
Yeah.
And he knew his wife was a physical therapist. You remember that. So he had but it was interesting that he brought that up at this meeting, that this is some of the reasons why the muscle related pains were so difficult to be managed because they were all over the place from the medical standpoint,
Yeah.
even before the physical therapist got involved into it.
Yeah. Very interesting.
You've done a fantastic job. I've been so honored to have met you early and followed your career periodically. It's been the greatest thrill.
Oh, aren't you the nice one? No, I remember you when the eccentric, I've been fascinated with the whole eccentric exercise thing. That's worth a whole nother time in itself for discussion. Yeah, it's really interesting work these days. And in fact, I had to change my exercise regime because the gluteus medius is eccentric working, and I was giving it concentric exercises. Well, that's a waste of time. Never too old, but too soon old and too late smart. That's what I call it.
All right. So it looks like we do have some questions for you. So I'm just going to kind of take them down through the chat here. Dr. Gutsenko, you're up.
Hi. Yes, I'm in motor control research. And so I do research on the automated assessment methods for impairment and function, and I use technology extensively. So my question is, what do you see the future of technology in physical therapy profession, especially in light of the current remote work and pandemic where we're all stuck at home?
Oh, well, we won't be stuck here all that long. I think, I'm kind of a Pollyanna or a half full person, and I think the increased use of these ways of communicating with each other via Zoom, et cetera, will be an advantage in communications for us. We won't be so isolated anymore. And I do think we'll be getting together a lot more. I know the research has been stalled on the WashU end as well, but it'll be back. It'll be back. I'm sure.
So what do you think wearable technologies and remote monitoring could bring into that?
If you could see me, I've got on 3 watches because I say at this age, something needs to tell me I'm moving. But I'm monitoring my heart. I couldn't be a bigger fan. I'm an 18,000 step a day person. I walk at least 5.5 miles a day. So I have it all clocked. I look at my heart rate. I look at my blood pressure. So I'm a big fan of what you're doing with the wearable technology. And then I could send it to somebody like you because we've got all of this way to do it. So I think it's a really good thing. I really do. My belief for the profession is, though, I think that our PTAs should be the ones that collect all this information while we do the big things like the blood going, the doctor sending the blood, or the EKGs, or the echocardiograms being done by other personnel. And then we put the information together. But you got to figure out what information we need. So I'm totally a fan. Totally a fan. Yep. I think it's got a big future, of course. I'm still bothered because I need the details that we can't get down to some of the levels that I think are the most useful, though. The exact joint precision, but we're getting there. Yeah.
Okay. So the next question was, that I think is a really good one from Dr. Rice, was, do you have an idea for a proposed name change? So what would you change it to?
Well, one of the funnies that took place in Helvetia, where this came up, and it wasn't, as I say, I am not the one that generates ideas. I'm just the one that hangs on to them. But I had suggested a name like Motician, and they thought it was too close to Mortician. So that got rejected right away. But I think that I'm just like I don't want to be a pathologist because that rules out prevention. Mm-hmm. But I'm thinking something like movementologist or movement systemologist. Yeah, something that has an ologist. I'm not committed to the name, but I think it ought to be in the ologist kind of category that speaks to that. And you don't have to change the name of the profession, but I think the reason why speech and them changed is that if you're a therapist, they expect you just to do something and not to figure out something. And if you're an ologist, you right away have a foot in the door to be recognized that you're going to figure out and that you're truly a doctor. And I am bothered about how smart the students are these days, how much they know, and without recognition for that. And then I think the time pressures for productivity, because money is such a big issue, is also working against us to have time to do things adequately.
Right. So we have a question from a student, so I want to make sure that we make time for that. So Jason Phillips said, I have a question regarding the topic of more visits and or yearly checkups. So Jason, did you want to ask any more about that?
Yeah. Hi. Hi, Dr. Sahrmann. Thank you for
Hi.
being here today. I'm Jason. I'm one of the third years here at WVU. You alluded to something earlier that I thought was interesting because you mentioned wanting kind of more visits or yearly checkups. And it's something I've kind of heard about before, the idea of it, where we think about like dentists or MDs, and it permeates culture. When you think of a dentist, you think, oh, I need my yearly checkup because I need to prevent cavities. The idea of that with PTs, in your opinion, how do we kind of sell that to the public and get that into the public mindset that, hey, I need to see a PT yearly for XYZ prevention? What are your thoughts on that?
That again, Jason, that's why the movement system is so important. People need to understand that movement isn't optimal just because you don't hurt. that there are ways that you have structural variations. We need to identify those so that you don't do things that you shouldn't do. Young girls with femoral anteversion shouldn't look for a career in ballet. It's not going to happen. They'll see the surgeon first. And so you need to know, not only that, you need to know whether you're, I go on the internet and just look at pictures of kids. It just makes me nauseous because they are not in the right alignment. They haven't built up their bodies appropriately. And the few I saw in the clinic. So I think that they should be coming in yearly for their movement system exam. They should know if they're exercising right, if their alignment's good. I'm a big proponent that you've got to have good alignment. I mean, you can be bent out of shape, but you'll pay for it in the long haul. And I think the analogy to dentist is perfect. You know, I always say the only thing you do with your teeth is speak and eat. You need your whole body for everything. It's always hanging out there, and nobody's monitoring whether you're using it right. And all you have to do is stand on a corner and watch people walk or move, and call 911 because that is scary. And they shouldn't come like I've got 6 visits and then I'm through with you. They should come like I am taking responsibility for this because movement caused this problem, and you're the only one that can. We've got to change it so that we're not ones treating symptoms. We're the ones that are figuring out what the problem is. And in some ways, I also take a lesson from nutrition. I mean, when I was growing up, it didn't matter what you ate as long we had too much. Now super have too much, but now it's a matter of you've got to do the right thing. And I think we have to show people that we are really movement experts. I'm also so regretful that we do not have a place in exercise. No one looks at us as exercise experts. I'm sure if you had a friend, I have friends, they wouldn't consult me about their exercise program for the most part. They'd go to a Pilates class or a yoga teacher and like, what do they know? A 6-week course? No, there's something wrong with that picture. Do you see what I mean? So yeah. That's what we got to break, this mindset of the physician sent them here with a problem. I've got 6 visits. I'm supposed to treat whatever the symptoms for the condition. And I actually, the way it was for me at WashU is they sent them to me for a diagnosis. They didn't even have the body part right most of the time. So I think that's the way practice needs to be.
Okay. Yeah, I think what you talked about earlier with the movement diagnosis, specifically giving them a diagnosis, kind of makes sense to me, because what's been, I guess, confusing or difficult for me is the idea of giving them something easy and simple that they can take with them. Like they can think, oh, dentist cavity. How do they make that? How do they draw that from PT and know that it's worth coming in yearly for?
I'll say to all the students, you have to have a systematic exam that you use for every patient that comes in with back pain. And the diagnoses are named for the movement direction that most consistently causes pain. So you tell this patient you've got a lumbar flexion syndrome. Like every time your back bends like this, you're getting pain. Now here's the reasons. Your abdominals are too good, which can be, it is, particularly in these days of intense workout. So yes, that's exactly right, Jason. You tell them and you show them the relationships and how they're in charge of their symptoms. and they're coming to you. They are.
Well, thank you for your time. I appreciate it. Thank you for the input.
No, I'm glad. Good question.
Thank you. Great, Jason. So, Shirley, one of the recent publications that you put up by M.R. Whaley is one of our fortunate, we're very fortunate to have him on our faculty. And as a matter of fact, he, I have no doubt, has a number of things to discuss with you. So,
Oh, well, that's good.
Mohammed?
Hello, Dr. Sahrmann. How are you?
I'm very fine. Well, great. Aren't they lucky?
Well, I am lucky to be here, actually.
Wonderful.
The first time I met you was in Grand Rapids, Michigan.
Oh, goodness.
I don't know if you remember me.
Not quite.
That's fine.
Well, I've got an old mind, so.
Most of the questions I have been already asked. The only remaining question I have is about your thoughts regarding the pain neuroscience perspectives.
You want to know where it gives me a pain?
Say that?
You want to know where it gives me a pain?
Okay, so I won't say more than that then.
Oh, no.
So basically the point, I don't believe in that human movement or malalignment doesn't matter. It exists in everybody. Don't worry about that. Let's just focus on treating the, basically what
Pain in the brain.
Yeah, pain in the brain. I mean, this to me doesn't make sense. Pain in the brain is just like saying without knee, there's no ACL injury. It doesn't make sense.
Well, good on you.
It's true, but everything is governed through the brain. So I want to know basically your thoughts, to cut right to the chase, about how can we blend what pain neuroscience people try to communicate with the movement system. That is where I sometimes feel that there is a conflict here.
Well, it shouldn't be a conflict. I think what I've looked through all the publications, and what they never say is the percent of people. Now, I was a clinician for much too long, and I knew there was a lot of patients who definitely had more problem with their pain than they did with the cause of that pain. And just like there is in every aspect of a condition. So the number one perspective is, what percent of patients are those? Number two, and that's the other point I was trying to make, we haven't done things where we show people what causes their pain and how to take it away. We've tried to do symptom relief.
Yes.
That's what medicine does, and that's why we have the opioid crisis, is because those are symptom treatments instead of cause treatments. And that was my whole practice, and that's the way my colleagues are. You show people in their simple everyday movements, and Linda Van Dillen has all these publications. And if you change the way people move, you show them how to move and they figure it out, how they're causing pain and what they need to do, you're putting them in charge.
Right.
You're not saying, I'm doing something magic to you. You're showing them how they're in charge so they can take responsibility. And then we use these diagnostic categories. So we give them names so they understand that we figured this out. I don't have any trouble with, I know there are people where it becomes exaggerated, but I do not want to be a psychologist. I want to be a physical therapist. I don't think they fully appreciate how movement causes pain. And Linda's work is really showing this. In fact, I even have a little thing where there's a study by Cornelia Kulig and Chris Powers and even Joe, and they do MRI and they push on the spine. The people with back pain got more movement than the people who didn't have back pain. Why do you want to mobilize more? I don't understand it. When that's what the problem is. So it's a matter of not jumping on the next fad. Do you know what I mean?
Okay.
And I think that's what's happened. It's come along, and the others don't understand what movement and all of that is about. It's not, and as I say, I've gone through the literature. I cannot find a percent, but it's at the most 12 to 15% of people that get carried away like that. And part of it is medicine's fault, not ours. And we're not going to talk them out of it. We don't need to. And if we can take care of the other 90%, I'm happy with that. Does that answer it?
Yes, it does. Yes.
Okay. Very good. Thank you.
Right. Another question from a student. So this is a good one. So this is, you know, your expertise as a leader in the profession. So do you think schools should put more emphasis on specializing in their curriculum rather than graduating the generalists before starting work towards specialization? It's a hot topic in the profession, isn't it?
I don't know. Is it? I don't think.
Well, the idea of pushing a lot of students immediately into residencies and fellowships and, you know, going that route, I think. Kyle, if I'm misstating, please jump in.
You got it perfectly.
Okay.
Number one, I think that in the 3 years that we have, and I think also there's a problem in many programs. I mean, this is going to sound like real heresy, and I don't know what you do there, but I'm not a fan of research projects at the basic level. I think you have enough to learn in your profession to, and I think with 3 years and what we don't have a whole lot of, it's seemingly a lot of control over, what that medicine does is that medicine, you get a good look at a specific entity as you go through medical school. And we teach neuro and musculoskeletal and all that, and then you go out and hope they have a clinical that gives them some experience in that. So that it's never like I'm spending all my time with a neurologist, I'm spending all my time with the orthopedist, I'm with a cardio person. And so I think that we need the general education at the level. My experience has been by the time the students get, probably they come with a bias of they want to do musculoskeletal, they want to do sports medicine. Everybody comes in with an ACL tear. We know what they want to do. And then some people want to do neurological patients, et cetera. So I think they know soon enough to go in that direction. I think the idea of residency, I think there's certainly some advantages, but I don't know where they're going to be. I don't know who's going to offer those residencies. We have too many people coming out of programs and not enough sites for them to go to. I know the University of Colorado, they were using residencies and half of the class has to just finish when they finish. And the other half of the class kind of gets a residency. So I think there's a practical aspect of this. And I think that's going to be worse after all this sorting out thing with the pandemic about clinical experiences. So I think my bottom line answer is I think there's a big advantage to having a general background. Medicine gets a general background. Also, their first year before the residency, they have to go do a regular doctor thing, and they've had 4 years and a lot of concentrated experience. And we need to get better at what we do right now. And then I think people will end up specializing anyway. Yeah, I think I can understand the financial advantages to the residency for people, but I think we're hard put to find good places for them to do that and to spell out what it should be. To me, one of the big problems we've got in the profession is the variability in practice. There's who knows what anybody does for anything.
Absolutely right there. Yeah, I think as a profession, we have to address that.
Yeah, and that's why I'm pushing diagnosis. So I don't know any other way except to get there.
Absolutely. All right. Any other questions?
I said all that and I haven't stirred enough questions.
Okay, speaking of diagnosis,
Yeah.
I mean, I like the name movement-enologist, if I'm saying it right. But in 2009, I suggested to my professor then and still mentor, Michael Timko and Tony DeLito, that we change our name to physical diagnosis and therapy. Without the word diagnosis in the name, people will assume that we just do things.
Well, I think you could handle that, remember, with ologist, a movementologist, or yeah.
Okay.
I don't think you have to say I'm totally in your camp about wanting to make a diagnosis. I definitely want to, but I think if we get rid of therapist, that's the most important thing, is getting rid of therapist.
Yeah.
I mean, we get lumped in. I mean, I've seen hospital bulletins where they put us in with music therapy or something other therapy. People that entertain and distract rather than people that figure out a problem. And I think that if you are locked in with the terminology that includes ologist, then you're more like the cardiologist, the neurologist, the ophthalmologist. You're saying, I've got a system about which I'm an expertise. And that's what you want to say. And I study that system. That's what ologist means.
Okay.
Yeah.
Thank you.
All right. Anybody else?
So have I at all made it clear about the movement system and why we need it? No.
Can I ask?
Very persuasive.
Pardon me?
Can I ask like a historical question?
Sure.
Nothing. I remember I read that Dr. Kendall delivered, I think it was a Macmillan lecture.
Yes, you did.
That called for changing, or that the body of our knowledge should be musculoskeletal.
You were
system.
exactly right. She did.
And then there was an objection, but the paper I was reading didn't detail about what was the objection.
Well, the objection was it left out all the neuro people.
Okay. And
nobody wanted to go peacefully, and particularly not at that time, because neuro was the biggest thing going at that time.
Okay.
When she gave her Macmillan.
What caused us to wait until 2013 to acknowledge that movement is our identity? Why? I mean,
well, we acknowledged it in 1982, that movement was an entity, but there's still not much understanding. And I don't know whether I've really done it well here, that you've got to put this into a system. And to me, what's so important is to say to everybody, this is a physiological system. I don't think it's that different from the metabolic system or the immune system. They're a system of systems, and that you need an expert for that system. And to me, it's totally different if you're going to be taking on the responsibility of a body system versus you get a referral for a pain in the knee and you're just doing exercises for an ACL repair. That is not the same thing to me. Not that that isn't important, but you should be able to look up and down that body to see, why did they get that ACL tear in the first place? You should be able to look at their conditioning. You should be able to look at all of those things, and you should be able to have them come back. They need to come back in a year because that's not even probably well healed, and they're at risk for OA, and they're at risk for the other knee going. Do you see what I mean? But we don't have that. It's come in, get your exercises for your ACL. Goodbye, I'll see you some, maybe probably never again until you tear the other one. That's not responsibility for a body system. And if you say, and then I've spoken, I think 2 or 3 times for the pediatric group, and I don't treat kids, I never did, but well, a few, but not much. And if I just go on the internet and I look at kids that are in a group exercise, it just appalls me to see the alignments that they're in. 50% of them, I want to call 911 or rush up there and say, well, how can I get in touch with this kid? They're in danger. So I think people don't realize the importance of how their body should function optimally. Okay. It may not hurt now, but then I always use the analogy, well, I'm not going to wait for my heart attack to know my cholesterol is too high. Just because my blood sugar is high, I'm going to worry about it now. I'm going to not wait until I get diabetes. And yet that's what's going on. And we aren't saying to the public, how you move is really important. You may not hurt now, but you will. And believe me, at my age, I know all about that. and I'm doing good, but I've got friends that are 10, 15 years younger than I am that I hate to look at them because they're a mess. They're a mess. Yeah. So I think that's our responsibility, and that's totally different than what we've been doing for 100 years. And that's why asking the student, what are you, I know what I would do. I'd be doing a physical exam on those people every year when they came in. I'd be wanting to see what the exercises were their coach prescribed for them. I'd want to know how they're playing their sport. What sports are they playing? I mean, little things, even in our students, like here's a boy with femoral retroversion, and he's doing squats with his feet straight ahead, and he gets hip pain. Oh, I wonder why. Because he's in medial rotation flexing, and he's got FAI, and he can't go down that far. I mean, so wait until the labrum's torn? Is that what we're going to do? It's just like, whew, there is so much for us to do. That's a big, long answer to a simple question, but that's what I want to convey is it's a total different responsibility. If you say, I am in charge of this system and I know more about it than anybody. And more important than that is I can take care of cause. I'm not going to just treat your symptom or your consequence. That's really, woo,
Yeah.
How much money could we save for people?
Yeah.
You know, let me just make this one point. When people study osteoarthritis, they get a little mouse or they get a little rat and they put a lesion in the medial meniscus of the knee and they say, go walk, you little rat. And you know what the rat gets? Osteoarthritis, because there's this little wobble in that knee.
Mm-hmm.
I really believe we're the people that could slow down the onset of osteoarthritis. And it'd be better to get it at 80 than it is at 50.
Mm-hmm.
And I think that's what our future is if we get it together.
Thank you very much. If no one wants to ask another question, I have one more question. I am sorry to ask these questions, but
here's a good one though. Yeah, go ahead. This one is about insurance pays. Okay, and I don't think certainly that's part of it. One of our problems historically has been people expect their physical therapy to be paid for by their insurance. Part of the reason why I'm so keen about the name change and diagnosis is people will come to us because their co-pays are getting up to what anybody would charge. I mean, and they need to pay that copay if they're supposed to 3 times a week. They got $60 copays. That, if they just knew that they could get physical therapy for about the same price or a little bit more, and they wouldn't be coming 3 times a week to pay that, it would be a totally different story. If we made a case that we have something to offer that's going to keep them from paying so much. It's again, like that dentist thing. Get your cavity taken care of. Make sure you're brushing so your teeth don't come out. That's a lot cheaper to have a cavity fixed than get a replacement. And that's what, if they had respect for us, which I don't think they have now, because they need the doctor in front of us to send them to us because the doctor knows what's wrong, not what we know what's wrong. And that's where the mess up is. So I think people will pay once they understand there's something worth paying for. And then go ahead with your question.
Speaks to the responsibility of each one of us in the profession is to take ownership of that and make sure that what we do is comprehensive, is of value, is worth paying for. I mean, it comes back to us as well. I think that responsibility.
And I do think that the other problem that we have generally is that students don't graduate with a systematic exam. They have a little toolbox, and they need to know. Now they can change it, but they should be able to hit the ground running. Mm-hmm. And that's going to make for efficiency. This whole idea of, well, let's see, what do I do next, and then what should I see? Well, it just can't happen in the world of practice today. And you can't learn from I learned a lot because we worked in these big open areas and we had patients forever. Now, if I see a patient, I go into a little room. Nobody sees what I do. They don't know what's wrong with that person. They don't know what they're like when they come back because people want privacy. It's a totally different, you can't learn on the job like you did before. It's just not so possible. And the push for productivity. Now you got 20 minutes, and then, because as we know, Medicare pays the same for whether you spend 2 minutes or 2 hours on your initial exam. And they want you to spend 2 minutes, not 2 hours. So I think diagnostic categories, systematic exam could make us more efficient and could handle some of these problems. And then feeling like I've got responsibility for this patient, and not just for their ACL recovery exercises or whatever. Mohammed, you had another question. Did I interrupt you?
Yes, I was thinking about, we are advocating for a movement screen, but there isn't actually a movement screen exam adopted by the APTA, for example, that PTs should know, or patients should be screened for these common movement impairments, and this is how you do it, for, you know, starting from the hip to toe kind of
There
exam.
is a little screen. And it's a very little screen because, and it's about basic movements. And I'm waiting to see how it came out of the summit thing, and then a group that worked on it. And it's very simple kind of things. And you just look at basic performance, like sit to stand, going up and down a step, and you kind of say it's okay or it's not okay, because we're balancing two things to get something that's general enough that it applies, whether it's a cardiopulmonary and they turn blue by getting up and down out of the step, or it's a neurological, they fall over to one side, or it's musculoskeletal, it hurts. And then it's what they need further. At least we could get on one page that everybody sees something, and we relate it to everyday activities. And then we can't add to the documentation burden that people have, because that's part of why I stopped seeing patients. I'm spending as long doing my documentation as I was treating them, more time actually. And so I think it's a balance, but I totally agree. We've got to get some kind of movement screen that says all physical therapists do this, just like they do a neurological. All neurologists, it doesn't give you a diagnosis. It just starts you down the path of trying to find something. And we could at least get on one page, which we are not now at all. Yeah.
Thank you.
Mm-hmm. Very good. Keep up the work.
Okay.
Keep it up.
Anyone
I have a
else?
question. I have one more question. So do you think the work that we've done with preoperative appointments, as far as even just doing education about possible deficits, pain, waking up and treating, like kind of preventing common impairments, could be translated to preventative, like a rationale for preventative visits for a healthy individual that's not about to have surgery? Like, is it the same research, but just needs to be translated to show its value? And we haven't done that yet.
I guess it's easy to say yes without by having a lot of specifics. I think, you know, number one, as much as I believe in all this, I know people still smoke. You know, so the reality is, what people are going to jump on the bandwagon of prevention. And I think that if we could just get out there and let people know that there are options, and it'll probably be the more highly educated people that already want to exercise, probably the older people that will get as responsive to this in the first place. But I think you just have to make a stab at trying to make it and make a point that this is important.
Okay.
Important to do. Yeah, I think there's much more attention to prevention now than there used to be in the past. As I say, I think about my growing up, and my grandmother cooked with these big cans of Crisco, and how my blood flows today, I don't know, because nobody thought it mattered what you did. You had to exercise because there was only one car and you lived a long way away, etc. But now we know we have to work at it. And I think more people, a certain segment of the population realizes this.
I was just thinking that, we do look at prevention when it comes to something that a doctor will still refer the patient. Like, what can I use as a trigger to get a doctor to refer the patient? They're about to have surgery, or, they have early COPD, something. We're looking for that trigger where we're not, I don't know how to translate that to a general healthy population.
Well, I'll tell you the truth. I think our big future is in cash pay. I don't believe that. I think that physical therapists are going to need a big gym. I think they're going to need to offer everything possible. I think they need to train their trainers so they don't undo everything that happened in physical therapy.
Mhm.
And I think people will come in like they're going to exercise gyms, etc. And then and then they'll build up a business this way. And you know, I used to have trainers that would refer to me, and I didn't mind letting them pick. I don't want to be the one counting to 10 because I get bored too easily, but I want to lay out the program and make sure that what they're doing is correct. So I see the future as very different for us. And I think we just need to establish the reputation. It's not going to, you know, we won't hit a tipping point right away, but we've got to get started on letting people know. And yours ideas about getting a niche out of those people, but I don't want to be dependent on the physician referral. And I don't want to be dependent on insurance companies. But then if you're not going to be, you've got to have a reputation that you're worth paying for.
Right. Yeah, I agree.
And that's why I see us having to sell ourselves in a very different way than what we've been selling ourselves before.
I have a question. So I'm one of those neurophysical therapists, and I agree with you completely about, you know, you alluded to this movement screen that everyone should do. And I wanted to know what your thoughts were on the use of clinical practice guidelines. And as you probably know, the Academy of Neurologic Physical Therapy came out recently with the core set of outcome measures used for individuals with neurologic dysfunction. And so I do that as part of a screen of individuals on every individual that I see, so I can look at them under multiple conditions and under different parameters. And I believe that everyone at some point in time, haven't figured out when that should be, should have some sort of balance exam, right? So you can establish a baseline, catch them before something's wrong, because we always get the referral after the fall, after something's already happened.
Yep.
And so they should get some sort of exam like that prior to something happening. So you have this baseline assessment, and then you can kind of monitor them over time. Like they come in for their yearly physical, they come in for their yearly balance assessment. So I wanted to know what your thoughts were on the use of clinical practice guidelines, things of that nature.
Well, I happen to know Patty Sheets pretty well, who's president of the neuro chapter. And I think the practice guidelines that the neuro section's working on, I think the last one was locomotion, if I remember correctly. I think that's good. My problem with the clinical practice guidelines for other conditions is they're on physician's diagnosis. And that doesn't, and they're not up to date. They don't, I couldn't follow them. I couldn't follow the practice guideline for low back pain that they have, or some of the other ones. So I understand the idea is to reduce variability in practice. Now, even with neuro, you're looking at outcome measures, but they don't tell you why they're in that outcome. In other words, you need subset of diagnosis to tell you what's the prognosis and what's the best way to intervene. And is this a force production deficit? Is it a movement pattern in coordination? Is it I forget what the other ones are, but you need sub-diagnosis so that people know what to expect from their outcome measure. The outcome measure just tells you. We have the same thing in musculoskeletal. How long does it take you to go from sit to stand? But it doesn't tell you anything about why you can't get there. Or you do the figure nines, but you don't know whether your knee is medial to your foot or lateral, and whether you're twisting it into an ACL. So you have performance things, but you need to know also how the body's working in relation to that, or in the neuro, what the major problem is. Do you know what I mean?
Mm-hmm.
Yeah. But at least neuro's doing something. They are working hard at coming up with diagnostic categories. So in addition to the outcome measures. So outcome measures are great. We need them to tell us where we are, but they don't tell you what to do or what to expect. Yeah.
Thank you.
Mm-hmm. Very good. Keep it up. Are there 10 questions? I see something in chat.
I think we're caught up on chat. Just got to hear about the cash pay, and I think you would get a rah-rah from most of us on that.
Oh, good. I'm all for it. I think it's the only thing that's realistic. We've got this 9% thing cutting.
And I think, the other thing, and is really determining who our audience is. So just as you get disgusted with seeing a prescription pad with check boxes, I get disgusted with marketing ourselves to physicians. We need to market ourselves to patients who will tell their physician they need to come to us.
That's what the drug companies did. That's what the drug companies are doing.
That's what the dentist did.
Yeah,
The dentist figured out cash pay 50 years ago.
yeah, and and our problem too is that once you're in the physician's model, then that talks big bucks. Like the dentists aren't connected with. I mean, what's the most you'll ever spend on a dentist? Do you know what I mean? It's small, and that's the way people need to think about physical therapy as well. But right now, we're just a widget in that great big costly box related to the physician. Yeah, no, I think that's why I don't know whether I'm so committed to this idea that we have to think about our being responsible for a system of the body so that we can stand alone. It's not like I'm trying to separate from physicians. I have great respect, but it's a matter that we've got to define ourselves in a way. And let me ask you all, do you see any advantage in using these terms, pathokinesiology and kinesiopathology? Does that make sense to you, or it's just another bit of playing with words?
See what if the students are nodding or awake or anything else like that. I mean, that's the audience. It's all about convincing the next generation coming out. Absolutely.
Okay, I think words matter very much. So what about the words pathokinesiology and kinesiopathology? Do those words make sense? Would they be valuable?
I think that they would be, oh, sorry.
Go ahead.
Hi, I'm Brandon. I'm the first
Hi,
year.
Brandon.
I think that the value only exists if they see some sort of a change. If they come to us and we have a changed name, but there's no difference in what they were receiving as far as care comes from a physical therapist, and it's not somewhat of a drastic change, then I think the change in name isn't quite as important. And so I think that there's advancements that need to be made in the way that we're practicing, in the way that we're caring for patients. And it's got to be something drastic from the old model before there's a name change.
But do you think that the name change would help facilitate the adoption of a new model?
I think that they have to go hand in hand.
Okay. I don't disagree with you, but I think if we spelled out more about what we're about, it would be easier for people to know how the model should change. If I said to you, you're a kinesiopathologist, would that be different?
As a person who got PhD trained at USC, I like that name.
I've heard of it. Yeah, the pathokinese part. I know. Well, they're still operating off of old pathologies. Now, hopefully you've gone beyond Chris Powers.
I was with Cornelia.
Oh, Cornelia, yes. They're all lovely people. I love them dearly. But I love to rat on them. Yes. That's great. That's great.
Dr. Sahrmann.
Yes.
Hi, Corey
Hi.
Mancinelli here.
Hi.
I think we also have to worry about accessibility. We have separated ourselves so much from our physician providers to worry about being in a situation, a POP situation, and other unethical circumstances, that the way around it has been, well, we'll just get an athletic trainer in our clinic to do what you would have otherwise done, or we will hire a kinesiotherapist or a movement therapist, as we're seeing all sorts of these types of individuals and names popping up. So I think that sort of goes along with what Brendan is saying. Yes, you can't just change the name. We have to really, really be a big piece of that. And what you were talking about with our thrust in diagnoses might be that, but it's to be visible and accessible in that way too.
Yeah, I often think about the same point that you're making, but I also know how there's part of why they're willing to take on this other person is because they don't know what we could contribute specifically.
Sure.
Yeah, so I mean, it's that's why I'm so keen that we have to really make our expertise known. And I can't, in fact, I will be having a paper coming out about diagnosis that was accepted by the journal. So I'm trying to spell it out even more. And I'm so upset that this seems to have been put on the back burner, but I can't think of another way in which physicians would really understand that we're figuring out something. I mean, I mentioned to you that one of the people that we're interacting with is Paula Ludwig. And I know she's published a paper with an orthopedic surgeon that she works with. And he just says so specifically, you look at the problem in a different way, you're going to treat it in a different way, you need a different label. And people, and they're now saying there's no such thing as shoulder impingement, you know, so, and they're actually saying, do you think it's the way you move? Oh, wow, such insight. But we aren't capitalizing on that. That's my point. We should be. There's the time is getting here where they're realizing that movement is something that is playing a role in these problems. We've got to let them know we can figure out that movement problem. Yeah.
Well,
Dr. Sahrmann.
I think maybe one more question. So this would be
Oh,
it.
sorry. So I'm Kristen Phillips. I am a board certified women's health specialist, and I'm a little bit gun shy when it comes to name changes because we just underwent a name change. And it took, pardon?
You're pelvic health people now.
Yeah, and I don't love that.
Okay.
So I worry because we made that change to be more inclusive, and then I worry that it's actually reduced what we do, because I treat a whole movement system, not just the pelvis. And so with kinesiopathology, I like it mostly, but I do worry if that's also gonna reduce us to a different system, or
I'm not trying to change the name to a kinesiopathologist. That's not the name change I think we need. I'm trying to differentiate between pathophysiology, pathoanatomy, and kinesiopathology and pathokinesiology. That, in other words, the expertise for the physician is in the physiological dysfunction of systems, or in the anatomical dysfunction of systems. And what the physical therapist worries about is the movement aspects, the pathokinesiology or the kinesiopathology, not the name, just the underlying. You are a pathokinesiologist, or you are a kinesiopathologist, depending upon when you get involved with that patient. Do you know what I mean? So is that really clear? In other words, if you have somebody that already has a lesion in their pelvic floor of some sort, you're going to do pathokinesiology. If you're trying to see them because they're leaking a little bit, you're in a kinesiopathologic process. You're
a diagnostician.
Yeah, you will be taking care of something where a failure to move correctly is causing a problem, but there's no pathological tissue. Is that clear?
Yes. Mm-hmm.
Yeah, but the name of the professional, that's something else again. Like it's just like physicians. They're all called physicians, whether they're a neurologist, that's a subset. You know what I mean? It kind of speaks to your expertise.
Well,
it seems to me like you have to get rid of the ist part completely. In other words, make sure the name, whatever it is, does not have any reference to any of the kinds of names that the doctors use. And that would be able to create this new discipline as an entity.
Yeah.
Otherwise, you're always going to have it. It's always just listening to this kinesiopathology and so forth. It still has that remnant. It's still medicine in some way. And you've been arguing that should not happen. We need to really have a distinct entity in itself. I don't know how you can do that with a word, but
well, but Bill, I do believe that the kinesio part is unique to physical therapy. It's not part of what medicine does. at all. I mean, the orthopedic surgeon looks at what tissue is bad and goes to cut it off or sew it together. And I think that if we jump in there with the movement part, then we will have that expertise. But I don't think that should be our name. I mean, that shouldn't be the title of the profession.
Okay. Well, things are getting energetic here.
Well, that's good. I hope so.
But we do need to be respectful of everybody's time.
Sure.
So, you know, on a Friday afternoon, I would like to have, let's everybody do the reactions and give a lovely round of applause.
Oh, that's good.
For Dr. Sahrmann. You can. I think she's given all of us a lot to think about and ponder as we get into this profession that we care very, very much about. So we're in this game together.
Well, thank you for the opportunity. And that's certainly what I want to do is promote discussion. I've obviously thought about this for a long time, so I hope I welcome any feedback. If you have my email, I really would be interested in comments about what makes sense and what doesn't make sense. So thank you very much, Anne, for inviting me and for this opportunity. And good luck to the birthplace of the movement system.
Thank you so much. All right, folks. Everybody have
Bye-bye
a good
now.
weekend.
You too.
Bye.
Bye.
Thank you. Thank you.
Thank you.
Thank you, Shirley.